Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to a new session from Spotter Cases. And we will start now. Okay, let's start the answers of the previous cases. Here the first case here is an area of abnormal signal, cortical and subcortical, involving the medial aspect of the left temporal lobe, with a characteristic location for infarction of the PCA territory, and this is confirmed in the MRA images. Here we can see that the left PCA, posterior cerebral artery, is non-visualized or occluded. So this is a typical form of left posterior cerebral artery infarction. In the diffusion weighted images, we can see here that in the ADC map, the area are high in ADC map. This confirms that the infarction is chronic infarction. So the typical answer of this case is left PCA territory chronic infarction. We must say chronic, as there is a diffusion here. ADC map indicate that the lesion is, or the area is, or the function is chronic in nature. And in a flare, even the flare, we can see the here area of likely CSF attenuation, but it is not apparently well at a flare, but it is well evident at the ADC map. So we must say that this is a left posterior cerebral artery chronic infarction. Okay, this is a typical example for the multiple subependymal nodules, which are characteristic of tuberous sclerosis, and we can see also these nodules in T1. It is apparently higher signal than the cortical gray matter, so this is not a subependymal heterotopia. And even we can see that there is some nodules or areas of abnormal signals seen subcortical in locations here and here. These subcortical nodules have a characteristic widening or flattening of the overlying cortical sulci. This is also characteristic for subcortical tuberous sclerosis nodule. So this is a typical features of subependymal and subcortical nodule of tuberous sclerosis. This is a characteristic location and signal attenuation of the second branchial cleft cyst. In this location, behind the angle of the mandible, cystic lesion within this location is a characteristic of second branchial cleft cyst, left side second branchial cleft cyst. Okay, this is a typical lesion with typical features of orbital lymphatic malformation. We can see here well-defined lesion present in the intracornal, predominantly in the intracornal space, showing characteristic multiple fluid level with no definite enhancement at the post contrast images. The characteristic fluid level is a pathognomonic for a lymphatic malformation. So this is an orbital lymphatic malformation. Okay, in this case, this is a typical example for the bilateral Schwannoma in T2 weighted images. Here, this is a cerebellopontine angle lesions with intracanalicular extension. They show rather homogeneous enhancement with no evidence of dural tail and the appearance of the ice cream cone. These features are typical for bilateral vestibular schwannoma, as we know that bilateral vestibular schwannoma or cerebellopontine angle schwannoma is a pathognomonic for neurofibromatosis type 2. So this is a typical case of a neurofibromatosis type 2 with bilateral cerebellopontine angle schwannoma. You must say that this patient is neurofibromatosis type 2 and bilateral cerebellopontine angle schwannomas. Okay, this is an intramedullary, well-defined intramedullary lesions opposite C6-7 vertebrae. This is a well-defined ovoid-shaped lesion with a characteristic hemosiderin, dark T2 signal hemosiderin cap with associated disproportionate edema and showing homogeneous enhancement at the post-contrast images. All features are typical for spinal cord ependymoma. The dark hemosiderin rim is a characteristic and pathognomonic for the spinal cord ependymomas, the disproportionate edema, the homogeneous enhancement. All these features are typical for spinal cord ependymoma. This is a typical example for the open spinal dystrophism. We can see an dystrophism here in the lumbosacral region, and we can see there is no skin covering, and this is the key for these features. For this case, is there is no skin covering. We can appreciate no skin covering in the T1 weighted images. We can see here the skin and subcutaneous, high skin and subcutaneous fat in a T1 weighted images, and there is no such high signal covering the defect here. And so this is confirmed the diagnosis of open spinal dystrophism or myelomeningocele. So this is a typical case for lumbosacral open spinal dystrophism. We must localize the dystrophism. We must localize the location. We must say the location or specify the region of the lesion. We should say this is a lumbosacral open spinal dystrophism or myelomeningocele. Okay, this is a case with multiple key answers. We can see here a liver cirrhotic liver with irregular outline. We can see an ascites. We can see the extensive portal vein thrombosis. We can see thrombosis involving the main portal vein and left and right branches of the portal vein. So this is a portal vein thrombosis associated with cirrhotic margin, a cirrhotic liver, and marked ascites. When we can see here, this is a gallbladder stone. This is a typical case with multiple key answers. You should answer the all finding here in the slide. Okay, this is a typical case with ACOM multilobar saccular aneurysm. This is a saccular aneurysm. We can see there is a multiple lobulation here, and we can see the origin of the saccular aneurysm at the origin of the anterior communicating artery. So this is a saccular aneurysm, multilobular ACOM saccular aneurysm. Okay, this is a typical example or typical features of the pulmonary alveolar microlithiasis. We can see the dense calcification involving the pulmonary interstitium, the peripheral and the central pulmonary interstitium, with a characteristic distribution and characteristic affection of the pulmonary interstitium. This is the typical form of the pulmonary alveolar microlithiasis. The extensive calcification and the distribution is a pathognomonic for the pulmonary alveolar microlithiasis. Here there is a large mass lesion occupying most of the left hemithorax and have an intimate relation to the mediastinum with a characteristic signal high in T1 and suppressed at fat-sat images. This is a characteristic for fatty lesion, so a large fatty lesion and with an intimate relation to the mediastinum. This is a characteristic for the thymolipoma, left side thymolipoma. This is a thymolipoma, left side thymolipoma. Okay, this is an easy case with MRCP showing multiple dark signal stones within the distal common bile duct and proximal biliary radical dilatation. This is distal common bile duct stones with proximal mild biliary radical dilatation. And this is a typical features of or typical example of the epiploic appendicitis. This is a rather well-defined fatty lesion, intimate relation to the sigmoid colon, so with the smudging of the surrounding fat planes. This is a typical example for sigmoid colon epiploic appendicitis. Here there is a multiple bilobar hepatic focal lesion. These bilobar hypodense hepatic focal lesions apparently showing no evidence of enhancement at the arterial phase and become more appreciated at the portal phase with a pancreatic body mass lesion. This is a characteristic of pancreatic neoplasm with pancreatic cancer with hepatic multiple bilobar hepatic hypovascular deposits. As we can see, there is no enhancement and the lesions are become appreciated at the portal phase, and this is characteristic of metastasis. The appreciation of the lesion become more obvious and become more evident at the portal phase, and these are features of metastasis and the presence of a pancreatic mass lesion. This is usually indicate that these lesions are deposits, and this is a pancreatic neoplasm. And the final case here is a typical example or typical features of acute hepatitis. We can see enlargement of the liver, we can see the marked gallbladder wall edema and extensive preportal edema. These features are typical for acute hepatitis. And thank you.